Necrotizing pancreatitis can occur in up to 20% of patients with acute pancreatitis. It is a life-threatening condition associated with organ failure and multiple complications, often driven by infection and hemorrhage. Necrotic tissue can become secondarily infected, and in this case, mortality rates increase from 12% in the absence of infection to up to 70%. Minimally invasive necrosectomy plays an important role in the management of infected pancreatic necrosis by draining pus, debriding necrotic tissue, and removing debris. The Dutch PANTER trial has confirmed lower rates of morbidity and mortality in patients managed by a step-up approach with an initial percutaneous drainage, followed by more invasive debridements based on clinical improvement. Here we can see the CT scan of a patient with necrotizing pancreatitis who has had percutaneously placed drains within retroperitoneal necrotic collections. When compared to open surgery, minimally invasive techniques result in decreased rates of postoperative organ failure and ICU admission. However, drains can fail due to the density of the necrotic tissue. These patients then require necrosectomy. When compared with open necrosectomy, minimally invasive surgical techniques consistently show lower rates of morbidity, new onset organ failure, and mortality. As part of the setup, we have 0 and 30 degree laparoscopes, a rigid nephroscope, and a 12mm laparoscopic port. The pulse lavage device itself is a single-use disposable system that consists of a hand pipe, waste pipe, irrigation pipe, and battery pack. It is a short and long nozzle, which is 30 centimeters long, which allows simultaneous debridement and lavage. The irrigation pressure at the tip is adjustable, with low or high pressure settings and a flow rate of more than 1,000 milliliters per minute. This facilitates rapid debridement and removal of necrotic tissue and infected debris. Patients are positioned supine with a wedge underneath the left shoulder and hip, aiming for 30 to 45 degrees tilt of left side up. The left arm is placed in an arm gutter and a pillow placed between the legs. The aim is to have the left posterior axillary line and flank exposed, providing adequate space below the drain insertion site to allow the operator to move the scope comfortably in all directions and not be limited by the bed. Prior to commencement, the CT images are reviewed by the surgeon to confirm the distance between skin to cavity and the direction of the drain, as well as the proximity between the drain and any other adjacent organs. The distance between the skin and necrotic tissue is measured using a wire or pediatric bougie. An incision is made at the site of the drain. An optical entry is performed with a 12mm OptiView trocar using a 0 degree 10mm rigid nephroscope. This allows access to the retroperitoneum without need for an open cut down. The port is advanced in direction of the drain, and visualization of the drain is maintained to reach the cavity. If significant pus is encountered, a suction system can be used with a 5mm camera. Once the cavity is established, the pulse lavage with attached long nozzle is introduced into the cavity and activated in short bursts, that is, 5 to 10 seconds each. This avoids pressure buildup within the retroperitoneum. To prevent any inadvertent trauma, great care is taken to avoid pushing against any resistance and avoiding movement of the device while it is active. The device is moved only along its longitudinal axis, that is, using a pushing or pulling movement or a twisting motion. The pulse lavage loosens necrotic tissue, which is then easily removed with graspers. Healthy tissue is kept untouched, thereby minimizing the risk of tearing any underlying blood vessels. If minor bleeding is encountered, temporary packing can be used, and if a bleeding vessel is seen, a clip applicator or energy device can be used for hemostasis. The majority of the patients will require multiple debridements. Therefore, it is important to adhere to a time limit, for example, 1 hour per debridement session. This will avoid potential fluid and electrolyte shifts, will allow borderline tissues to demarcate and declare themselves, and also avoid surgeon fatigue. The surgeon can continue to alternate pulse lavage with grasper debridement until the effluent fluid from the sinus tract is clear and the cavity appears macroscopically clean. At the completion of the necrosectomy, a large bore drain allowing irrigation is placed and secured. As seen in the bottom right-hand side image, this is usually a large bore intercostal catheter with an infant feeding tube running through it as an irrigation conduit. This drain is measured and cut to the same length as the previous drain, or using the laparoscopic port as a guide. A stoma bag is then placed over the drain to manage any leakage from around the drain site. Normal saline irrigation is then commenced at 100 ml per hour. Our case series includes 16 consecutive patients undergoing water jet assisted minimally invasive necrosectomy between January 2017 and October 2023 as part of the management of infected pancreatic necrosis. There were no complications directly related to the necrosectomy, no vascular injuries, and no patient mortality. Pancreatic necrosis is a dangerous complication from acute pancreatitis, and if infected, mortality rates can climb up to 70%. Removal of the necrotic tissue and evacuation of the infection is necessary to reduce the systemic inflammatory response. Open necrosectomy is associated with high morbidity and mortality. The advantages of the step-up approach, using minimally invasive necrosectomy, are well established. The use of the pulse lavage device facilitates efficient debridement and suction of necrotic debris and tissue, as is commonly seen in superficial soft tissue infections, and therefore is a useful adjunct as part of minimally invasive necrosectomy. Pulse waterjet dissection in a swine liver model has demonstrated that the pressure required to dissect healthy liver parenchyma is 14 bars of pressure, and the pressure required to dissect the hepatic vein is 86.6 bars of pressure. The pulse waterjet device has a maximum pressure setting of 1 bar, which safely fragments necrotic pancreatic tissue without damaging healthy tissue. If the waterjet is positioned a short distance away from the necrotic tissue, an additional margin for safety can be achieved. The water pressure will drop by 50% at 3 mm from the nozzle tip and by 90% at 3.5 mm from the nozzle tip. In conclusion, our overall experience has been that the pulse lavage device is safe to use in this setting and is a very useful adjunct in assisting minimally invasive necrosectomy. A future direction of research would be through the development of a specialized device which allows simultaneous camera and pulse lavage settings.